This is Bill Carlson from Café on Tampa. Because of COVID-19 and safe distancing, we're not allowed to meet in person. So we're experimenting with online interviews just to keep everybody going. This one is an interview with Dr. Jason Wilson, who has been from Café. You might want to turn your volume.
Yep.
He's been a friend of Café on Tampa for a long time, used to come regularly, spoke to us before. And he happens to be an ER doctor and a professor. And Jason, I'll let you tell us all about what you do.
Sure. Thanks for having me, Bill, and appreciate everybody being here virtually and early in the morning. So hopefully you're having some breakfast while we're sitting here chatting a little bit. And kudos to Bill for getting the technology working. It's not easy to get Zoom going and then double broadcast it out to Facebook. So pretty impressive. So I'm an emergency medicine doctor here at Tampa General. Been here for about 12 years and have a couple roles here. I'm a frontline emergency medicine doctor, so I see patients. Then I also have a role in administration. I'm one of the medical directors, so I have an operations role that has been heavily involved recently, of course, in how we respond to COVID-19, which I'll talk about. And then sort of have a role as a researcher and educator in that, researcher role. Really witnessed something I've never really witnessed in these, this previous decade before. And it's been just a rapid scale up of research technology, both, getting protocols set up and running, but also moving lab-based or research-based models right into the public, to the bedside. So what I'll do is I'll spend a few minutes talking about how we've responded to COVID and what that actually looks like here. I know what you're seeing on TV right now is mostly coming from New York City. So I think it might be interesting to kind of talk about what we're actually seeing locally in Tampa and how that's looked and what kind of changes we've had to make. And I'll talk a little about the research aspect of this, some of the innovation around it at Tampa, and then a little bit about what to expect in the future of the next 20 minutes or so. So overall, the first case in Hillsborough County of COVID was February 28th. I was sitting in I was about to actually go into work for a night shift, and I got a call on the way into work from our hospital epidemiologist, Sita Lakshmi, and our COO, Kelly Cullen, and basically said, hey, we've got notification that there's a case, and we just need to have a strategy around how we're going to deal with that if this happens at Tampa General. Right now, the first patient was a pretty young, healthy person, and they didn't really require, hospital care, fortunately. And so it wasn't an issue for the hospital, but we hadn't really formally considered yet what would happen if somebody walked through the door of TGH and said, hey, I think I have COVID, or, I've got symptoms of COVID, or they were a, potential COVID patient. So from there, we kind of started thinking about what our hospital looks like and our ER looks like, and started thinking about how to operationalize a flow pattern that would match, potential people coming in with COVID. And we had no testing at that time, remember? So there was, at that time, you had the CDC testing, and it was really strict. Like, we had patients in that first week or so, or, looking back on it, they clearly had COVID, but the CDC would not allow us to test those patients that first week of the outbreak. The CDC just didn't have the test. They were, to be fair too, they were also trying to figure out the disease itself, right? So during a rapidly changing pandemic like this, just like an H1N1, which I went through as well, the guidelines sort of changed every day. Same with Ebola, right? The guidelines kind of changed every day, and Zika, because you're trying to figure out the science too. So some of it's, of course, the politics and the structural issues and failings.
All right, Jason, when did you say that was? When was the beginning for you?
This is like late February 28th, I think, is that first case. And if I have one day off or something, but it's that Sunday night right there. I definitely remember, getting a phone call on my way to work and having a conversation around it and starting to really think about it, in a responsive kind of way. And, thinking about how are we going to actually take our ER and make it safe for patients who don't have COVID and potential for patients to do. And we hadn't seen the outbreak. I mean, Italy really hadn't even happened. It was about to happen, right? Italy was kind of just ramping up in terms of how bad Italy was getting. But, New York City hadn't happened yet. We knew it could be bad, but we didn't really know how bad it could be. We hadn't seen that yet. So testing was limited. So early March, we started to really think about, without that, two decisions, basically. One, testing's so limited, should we come up with some kind of testing here at the hospital? So this is where just a deep bench long-term investment kind of pay off. So this hospital laboratory here, it's like any major university laboratory, or essentially a major academic center laboratory. It's a huge lab. Angie Lauster and Suzanne Silbert run the lab. Suzanne's our PhD. Angie's like the lab and scientist director. They are really experienced in kind of turning over and setting up rapidly. We had a Zika test here early. We had, so they're used to kind of creating things quickly when manufacturers, sponsors don't have those materials available.
Still have any Zika cases coming through? Is that still around?
No. It's just, I think, there's a couple similarities here in terms of response, and it's, H1N1, Zika, Ebola, and this, are all just kind of places in my head where we had that same group of people gets together, right? You got to have these same thoughts. Of course, this one's different in the sense of Zika, right? Because you're concerned about person-to-person transmission. So a different ball game, but still some of the same concerns. So early on, we decided, I think, a really critical decision, which you, I think, know from the news and from everything you're hearing on TV, that testing was going to be important. And so there was, some internal discussion about whether or not we should stand up testing here. But I think one of the critical decisions that really saved this area, not just this hospital, but this entire area, was a decision for Tampa General to come up with a test. So Tampa General basically worked for 6 days straight, 24 hours a day. That lab worked on creating it's called an RNA PCR test. So basically the coronavirus itself is a little piece of RNA. RNA comes from DNA. And so you get this little RNA thing that makes protein. And the virus itself is RNA. And if you could replicate that little bit of RNA that's there, you can detect virus in somebody. And so PCR is that cyclical replication of virus for diagnostic testing. So they created this RNA PCR test, which is very sensitive. As a matter of fact, you're hearing, it's not quite clear in the news, but you're actually hearing a discussion about two different types of tests right now. One is PCR testing, which is way more sensitive, and one is antibody testing, which is probably not as sensitive.
Do we have antibody testing? Sorry to jump ahead a little bit.
No, you're fine.
Do we have antibody testing here yet?
So we kind of have antibody testing here. So Abbott has a FDA waived line for antibody testing. It's really early, and it didn't go through kind of the normal channels we would expect these types of testing, diagnostic testing, to go through. And so there are some questions about it. Some of those questions are, does it detect other coronaviruses? So there's, 4 or 5 other coronaviruses out there, and some we all get, every year, and it doesn't really cause much of a problem. So it doesn't really help us if you have another coronavirus that's not COVID. So there's some limited availability of that Abbott line antibody test. There's also some private labs around here that are trying to stand up antibody testing. And right now the FDA is allowing them to do that. So there are a couple other smaller companies we've been working with.
When do you think that will be widespread?
We're really close. I think we're really, really close. So there's 2 parts of that part. There's something called the IgG antibody and something called the IgM antibody. The IgG antibody is going to be really helpful from a surveillance standpoint. It tells you if you've been exposed to disease at some point. The IgM antibody will be more of an acute thing. Do you have a disease right now? We're much closer to the IgG portion than the IgM portion, which is okay. Because as we start to think about this, what we have to have is both a ability to test, to diagnose you with disease, but also a broader surveillance strategy to try to figure out how to get people both back to work safely, back on the front lines of healthcare safely, and then also return to normal life activities, right?
So it seems like your staff or the frontline first responders would be the first to get the antibody test. Have frontline people started getting that yet?
Yeah, so in a research format, that's exactly kind of where we're at right now, Bill, is we're thinking about how we could start to bring in frontline staff, test them, and then use that information to potentially return them to work or put them back on the front lines in COVID areas. So that's kind of in a research space right now, but that's exactly what we started with. We've been fortunate that we've had a very small number of employees test positive for COVID here. It's a very small number, but both testing the antibodies in those folks, and then also coming to our first line responders, our ER docs and ER nurses, ICU docs, ICU nurses who are working in the COVID areas, testing those folks and seeing if they may have had asymptomatic, had the virus asymptomatically, and see if they have antibody now.
Hey, just for anybody just logging in, this is Café on Tampa Online. Since we're not able to meet in person, I've got Dr. Jason Wilson, who's a professor and a consultant and also ER doctor at Tampa General, who has studied these issues thoroughly and is giving us all kinds of advice this morning. So Jason, what else was different about Tampa, and how do you think that will help us, the way we looked at it in the beginning? How will it help us to get through this?
Yeah, so I think we took it really seriously from the beginning. I think that the testing was a game changer, right? You have to understand the virus itself. You have to be able to describe who has it, what it looks like, what are we missing cases or not. Let me actually talk about that for a second. So there's been this sort of kind of worry that maybe we didn't have enough testing at the beginning, and were we underrepresenting the number of cases we had in this area because we couldn't keep up with like the demand for testing. So maybe there are all these cases out there that we didn't recognize. If you actually look at the Department of Health data for like the types of presentations that are coming into hospitals and emergency departments, you really see a flat line for things like shortness of breath, cough, fever. It's a really pretty flat line until around March 10th or March 12th. And then that line starts to go up. So I think we did a pretty good job of timing both our diagnostic test capacity, our response, and the actual arrival of COVID here in Hillsborough County. I don't think we were behind the 8 ball. I think we had everything ready when the real peaks, the real slope started to kind of form in Tampa. I think we were right there on time. We had testing available by March 12th or March 13th or so here. And as that's gone on, the amount of testing we've had has scaled up as well. As different machines come online, different types of reagents can be used. We're utilizing research innovation, 3D printed swab now. Tubes, the bag, the people to do it, all those things. And it turns out that the swab itself is one of those things that are in short supply. Those swabs are actually made in Italy. So you can imagine there's not much supply chain or material coming out of Italy right now. So we kind of realize we're on our own for how much swab we have. And so USF is turning over these plastic printed swabs for us pretty quickly now.
Are you in short supply of anything now? Is there anything that's still?
So I wouldn't say we're super short on supply. I'd say here's the thing that's changed. The thing that's changed is like all the normal supply chains we had are disrupted. And we can't really count on anything coming in at its normal cadence. So, before you might place an order with a medical device company, you expect the order to arrive. That's just not going to happen right now. It's just hit or miss. So it may arrive, it may not arrive. For years, everybody's kind of had a pretty good understanding of how many N95 masks they need, or how many gowns they need, or how many face shields they need, how many reagents they need. And that kind of just has moved over time. So of course the companies ramp up, keep up that supply at the same demand. So now everybody's demanding way more of all that material. So we think about it, when we make decisions about like PPE, like what you should wear for PPE, we try to make those decisions not just based on what's the best thing right at this very moment, but what's going to be the best thing throughout the entire outbreak, right? Given the fact that we think we probably only have this amount of supply on hand. So we haven't run out of anything. When we make decisions to mitigate our supply, it's really about trying to extend that supply as long as possible, thinking in our heads we may not get any more.
Let me just say for folks that are watching, it's funny, I've got several friends from Singapore who are watching. If you all have any questions, post them in the comments and I'll try to read them and ask Jason. But Jason, let me ask you, you're a policy wonk. You've been posting lots of charts online. As you're looking at this around the world, Singapore had a different tax, Sweden has a different tax. What are the lessons learned that we think from looking around the world? And more importantly, I imagine that just like, we went through Hurricane Charlie and suddenly then we had 3 more hurricanes in a row. By the fourth one, we knew better how to address them. People already had their plywood in their garages and may still have their plywood. What do we need to do next from our own experience and then looking at how other cities and other countries have addressed this? What should we do next to be prepared and how would we deal with it? Would we do a lockdown again or would we do something different?
Yeah, so one of the things I say quite often is that there's now a new tool in the toolkit for public health intervention that did not exist before. So, if you really go back to the two towns in Italy, and you kind of look at the town that got hit really hard and the town that maybe didn't get hit so hard, you can really see a difference in how they did non-pharmaceutical interventions. That's the fancy term for social distancing, non-pharmaceutical interventions, how they kind of operationalized those really early in the outbreak. And what you kind of realize when you look at that, you start to see their curves, and one gets hit really hard and one, not so bad. You realize early on, you're seeing essentially a ethically okay sort of social experiment taking place in policy that I don't think we've really ever seen before. I mean, I get 1918, there might have been some social distancing going on, but not on the scale that we're seeing here. And so, I think we saw that early on, and we basically thought about doing the same thing here. And we, of course, in Hillsborough County phased it in, right? We first had some recommendations about not being in large groups. Then we had early closing of restaurants and nightclubs. Then we had a full stay at home, safer at home strategy. And then eventually the state did the same thing. And it makes sense that those things might work, but a lot of that was sort of speculation based on some modeling data that had been done before, mostly at Stanford, about how much you would decrease your interaction with other people for each of those different levels of distancing. And then how much you decrease your interaction changes this little thing called the R naught, the amount of people you transmit virus to. What I think we didn't know is how that actually looks in real life. And what has been incredible about this is that we basically got a randomized controlled trial out of this, right? We got something you really can't do in public health very often. You got countries, populations, regions, areas that made different decisions. And we got to see basically what the effects of those different decisions were. And I mean, look, it's overwhelming that there's a difference in those decisions, right? There's overwhelming evidence now. There's a difference in the number of lives saved by making one decision versus the other. And so for those of you on Facebook who've seen some of the graphs I've had, you can definitely see in Hillsborough County, at the very beginning of this outbreak, we're following along the same curve that every other country has, because the virus itself has kind of a predictable growth rate. Like, you've got a population of people it can infect. It goes through and infects those people, starts to run out of people, starts to run out of steam a little bit, and dies down a little bit. But the longer you've got people to infect, the more it's going to kind of stay up on that plateau. And if you look at us compared to like Italy or other places, we were riding right along that for the first couple of weeks, but very early. So remember, February 28th is our first case. We've got testing by March 13th. You start to see some pretty aggressive social distancing strategies in this area. I'd say March 23rd is a big hallmark, because March 23rd is the day kids would have gone back to school. Before that, you saw the restaurants. And if you take 2 weeks after that, you actually see our trajectory, where we were heading in Hillsborough County, really shifts. It's like the hurricane shift, right? You think it's coming right for us and something happens. And that something looks really tied to the beginning of social distancing strategies. And then even the last couple of days, you see another kind of bend in that curve, which goes back to the more intensive social distancing strategies. So I think we have really clear evidence now that some type of social distancing works, whereas before it might have been speculation, before it might have been a theoretical idea that no one thought was possible, either philosophically or pragmatically.
So do you think if this happens again, this could come back, they say in the fall, or there could be the new version of this, like the flu, or some other something else that we don't expect that would come up? Would you think that the next time we would do social distancing too, or is there a way maybe to catch it early, create some antibodies and create a vaccine? What are some of the other solutions you think we might use to address this in the future?
Yeah, so there's two things there. One is this virus specifically, and one is general public health strategies, right? So for this virus specifically, what we have to start working to, so the whole idea early on was that instead of getting a big peak and have everybody die because we overwhelm the healthcare system, we keep this thing going for as long as possible, so with new technology can come around, we can start to bend the curve over time. Now, the idea behind that is we can stand up surveillance systems, right? So we can, three things I would say. One, we can come up with some kind of serological antibody monitoring system, right? So just like when you start a new job or you, go to a new university and start school, they may ask you to submit blood work to see if you've had chicken pox and things like that, or vaccines to things, right? So we could be in the same place with this. We could look for antibody against the virus. So that would be one way to look for some herd immunity, some specific personal immunity to do some surveillance in the setting of probably more diagnostic testing, some kind of testing pattern. And then two, it would give us time to, of course, develop a vaccine, right? Which is the other thing that this virus is going to need eventually. And three, you mentioned Singapore and South Korea. Some of these other places have more intensive contact tracing strategies, right? We probably need to have an automated contact tracing strategy. So you're starting to see some technologically based ones pop up. So Google and Apple are coming together to create an app. We're going to probably need to see something like that if we want to kind of get to that, like, I don't know if it's the third phase or fourth phase now. I haven't had time to kind of digest all the new, reopening scenarios. But if you want to get to the point where we're having large mass gatherings, you're probably going to need some kind of contact tracing strategy where you can rapidly isolate, rapidly do contact tracing. So that's for this virus specifically. But as a general public health strategy, I think the thing that has changed is you're going to see this type of non-pharmaceutical intervention, social distancing strategy be on the table and be a discussion in future outbreaks. So if you go back to 2009 for H1N1, I think hands down, this would have been a strategy we considered during that spring outbreak while we work, because we know we can get a vaccine to flu. So, but you have to have some time to do it. It takes a few months to get it ready. So I think we were probably seeing some kind of social distancing while we got that vaccine ready. So it's changed.
So one question we're getting is, after SARS, I traveled to Asia a lot. There are these just like you go through a magnetometer, there are these big thermometer things as you're walking through. They measure whether you have a temperature. So one of the questions someone asked is, what about, is temperature a good indicator? I think there are a lot of people that are asymptomatic, right? So how good of an indicator is temperature?
Yeah, it's a fair question. Sometimes temperature lags to the rest of the virus. It can be a late sign. Having said that, there are some ways to utilize temperature as well. So for one, like any public health intervention, you're not going to get everybody with one intervention, but you're going to get some. It still decreases the numbers a little bit. So it is true that if I check everyone's temperature on a single point one time, I may not capture everyone, but I may capture 40%, 30%, 20% of the people at least, right? Now, the other thing is, I think so places like Tampa General, other essential businesses that are staying open, most of us are doing daily temperature checks. Now, daily temperature checks are a little bit different, right? So every day I walk in, I get my temperature checked. It's more likely they're going to pick me up early, versus late. And they ask me, and that has to be in conjunction with some symptom signs too. Do you have a cough, cold, any upper respiratory tract infection symptoms, basically? So I always look at it, when you look at one public health intervention by itself, it's not going to work. It's not going to capture everybody. But if you take in the totality and the context of a number of different strategies, then you can get at it that way.
You talked about herd immunity. I have little kids, and when I take them to a playground afterwards, I'll use Purell in their hands. And a lot of parents say, don't do that because that affects their immunity. It's good for kids to get sick. So in a situation like this, if social distancing is a strategy, is that going to hurt our long-term immunity? If we stop shaking hands with people, stop getting close to people, we won't catch things as easily. Is it possible then that we won't build the incremental immunity, and then at some point the super version of these viruses will come out and wipe more of us out? What's your take on that?
Yeah, so the way to look at this is different viruses have different virulence. And what that means basically is some viruses are deadly to humans and some are not. Some bacteria can coexist with us really well. Some cause infection, right? So there's different levels of what a bacteria or a virus can do. It is important overall that we as humans are exposed to non-deadly pathogens, because non-deadly pathogens help us build immune responses that are not innate. So half of our immune system, essentially, we are born with, it's innate, which is given. And then the other half we develop over time. But we can't develop an immune system over time if we're dead. And so you've got to have some endemic pathogen out there, but a novel virus is not the place to have that endemic pathogen. This is for that to work, you've got to have already developed some evolutionary strategies as a species to deal with or coexist with that pathogen. What we have right now with COVID is a virus that no one's seen before, and no one and no human up until now has had antibodies for it. So, overall, when people talk about Purell and soaps and things like that, the concern, of course, is that you're going to allow bacteria to evolve rapidly. And whether that's true or not, I think is sort of not relevant to this discussion. And again, also the using Purell to clean hands during a pandemic is probably a lot different than having only antibacterial soaps. And by the way, it's not the antibacterial or the antiviral properties of these soaps or alcohols. It's really it's the soap itself. It's the lipophilic soap itself. It's the fact that this virus itself has a envelope around it, a membrane around it that completely falls apart when it's exposed to soap. It just sort of melts it away. And that's just the way the virus is made. And that's the same with the Purells. It's the alcohol that's really doing it. That alcohol can take the proteins off the viral membrane. It kills the virus that way, or makes the virus inert that way.
That's the best way I've heard it explained so far. Somebody's asking about deaths from the flu. Is it easy for you to tell right away? I know they're tests for both, but is it easy to tell who's dying from the flu or who has the flu versus who has this?
Sure, that's a great question. So let me talk about the flu for a second in general. So we see data that deaths from the flu over time are high, and they are. There are still deaths from the flu. Having said the way the CDC reports flu data is that it's kind of flu-like illnesses that all get clumped together as the flu. So it's a little sloppy in some ways, because what they're actually doing is they're collecting numerous viruses and unknown causes of death that feel like the flu, and they're putting them in one bucket. It's a fairly big number from that. And I think it sort of has confused the public because it artificially elevates the explanatory factor of death to one thing when it's really a bucket of a lot of things, okay? So it could be influenza A, influenza B, other types of viral upper respiratory tract infections, all lumped in there together. What we're seeing different right now with SARS-CoV-2 is one virus that's causing more death than its entire bucket of viruses over here. You see one virus is causing that much death. Now, the other problem with that too is that I don't think people recognize that the yearly cycle of upper respiratory tract viruses, which includes influenza A, influenza B, viruses we don't know, coronavirus, rhinovirus, all those things, they cause flu-like symptoms, like the cultural term flu. Our healthcare system gets it at, I don't know about capacity, but definitely we're getting there, right? It gets busy in the winters, definitely in Florida especially. Now, if you take another virus and stick on top of that, right, then we get worried about moving over that capacity bar. We may increase our capacity so much we pass capacity. So the question is, can we tell the difference between the two? Yeah, we're actually pretty good at being able to tell influenza A and influenza B. Our testing strategies for that are pretty robust. Early on, back in H1N1, they were not. We were using a lot of antibody testing, which again is not as specific, but the PCR testing is very sensitive and specific for influenza A and influenza B because we have the whole thing sequenced, so we can usually tell which you have. Early on in this outbreak, we were trying to conserve tests so much for the COVID virus that we were actually testing you first for the flu, and if you were positive there, we would not move on. We would just say you have the flu. We did a lot of that at first, and now it kind of looks different. They look like different viruses. The COVID virus is almost more of a lower respiratory tract virus, which is why people probably get some GI symptoms too, because the lower you get down here, the closer to your diaphragm, the more the belly might get involved, the more it might get into the stomach and other GI tract areas. So they just look a little different. Flu has a lot of muscle aches, fever. This COVID virus has a lot of cough and shortness of breath and chest pain.
You think there were a lot of people that had both that weren't tested for COVID?
No, I don't think so. So it's interesting. We actually did a lot of, so after we moved from our single serial strategy, we did a lot of testing of both. We did a lot of, we can test for about 15 different viruses at once already. And then we can also test for COVID now. So then we kind of moved into a strategy of doing that for a while. We had zero patients who had two things. So we had no patients who had COVID plus any other virus. And this matches the literature that we're seeing overall. There's been a few little clusters of people who had maybe 15 or 20% viruses, but otherwise in the entire world, we've really only seen either flu or COVID, either rhinovirus or COVID.
So a big question I want to ask, and I think some folks have kind of alluded to this too. since there's not widespread testing, I mean, I think the way to know what the infection rate is we'd have to do big random samples, right? So, or have a census. But are the deaths or the cases that you're seeing, is there some science that shows what the indicative infection rate is based on that?
Sort of. You kind of said it, that you'd have to do some kind of public surveillance program to really get at it. I would say we are moving closer in that direction, though. As our diagnostic test strategies increase, we can get closer there. Just to give you some ideas, the number of people we test the emergency department that are positive has been around 7% of the people we test that are positive has been around 7% of the emergency department. Now, through the entire system, through like outpatients, USF, TGH system, it's probably down to about 4%. So in other words, sicker people coming to the ER, right, have a higher seroprevalence, are more likely to be positive. What's going to help is now that our diagnostic testing has increased, as we start to think about how do we coexist with this virus that may exist in our community at some level for a period of time, but also start doing surgeries, seeing other patients in the emergency department, doing other things. Maybe do more widespread, not I wouldn't even say testing, but screening. They were going to screen more people for virus with the diagnostic instrument, a diagnostic test. I separate those two things out because when I test somebody, that means I think you might have the disease. When I screen you, I don't think you really have it. I'm gonna do some public health measures. I'm gonna make sure, right? I'm gonna try to make sure the hospital's safe, that our community's safe. So I think what you're seeing us move into over the next month or so is that public health surveillance mode with a testing program on top of it. And as we move into that with higher volume testing, I think we'll get closer to be able to characterize what this looks like in the population itself.
And so what do you think, one of the questions is, what do you think the next few months look like? When will some people want to go back to work right away? Some people would rather stay home because they don't want a second wave. Looking at from your scientific point of view, what would you think would happen over the next few months? What would you suggest happen?
Yeah, let me start by saying that if we just turn the key and said, you know what, let's just go back to the way it was, we will have in New York. That's like, there's no way around that. We can't just go back. Like we can't. My favorite time of year is the spring because you've got baseball, you've got starting basketball playoffs, hockey playoffs. It's awesome. Like I want to go to all those things, but we can't do that right now. So the question becomes kind of how do you get there, right? And so some type of phased in approach is sort of how we have to look at this. And I think most of the modeling and work I've done has been what we call data driven versus assumption driven. So we've looked at people who are ahead of us and we've tried to model what might happen here based on our population characteristics, our capacity for things, what might happen here if we get on the same curve or have the same outcome. So what I mean by that is, we were following Italy for a while, we've fallen off of Italy. Now we can start to look at places like Denmark, Hokkaido, Wuhan, maybe other states in the United States that are starting to relax social distancing measures. We can start to see what their probably sawtooth patterns, how you would describe it, you're going to see as ups and downs, ups and downs, ups and downs. I know a lot of policymakers are really hesitant about reopening and then having to re-shut down, but we're going to have to be willing to do that to be able to do this safely at any level. We're going to have to be willing to say, let's relax a little, let's tighten a little, tighten over here, relax over here. Certain groups could be relaxed, other groups maybe not so relaxed. So we're going to have to consider that because we're going to see, to kind of summarize that part, what we're going to see is probably some prevalence of disease that exists in the population, right? So maybe at Tampa General, we're always going to have 10 people, admitted with COVID, right, for the next few months. Hopefully that doesn't spike, but we may occasionally see little clustered outbreaks, right? You may see a nursing home outbreak, a facility outbreak, a cruise ship. Well, I don't think we have cruise ships for a while, but some kind of other outbreak, may occur. You kind of deal with that, put that fire out, and then kind of get back to this. And then how do you layer things on top of that safely without causing surge of demand and overcome your capacity?
So thank you everybody for watching. And by the way, we're going to try this experiment maybe even every day. We've got another one this afternoon at 3. I'm interviewing Tony Zapponi, who's a longtime Tampa guy with lots of great stories, and we're going to do a few next week too. So watch Café on Tampa event schedule. Jason, last question. Walking Dead. Sorry to mention this. Walking Dead is one of the most popular shows in America. People watch these dystopian shows about the future. Hopefully we don't go to that extreme, but what is the future going to be like? I mean, how will, someone asked, what are the lessons learned, and what will the future be? What will we need to change in the years coming forward, not just as we get out of this, because we expect that maybe more like this will come.
Well, so for one, I mean, I think understanding that a pandemic response and thought team, in our federal government's critical, right? So we got rid of that a couple of years ago. That's probably going to be a critical piece to have and understand that, just like looking for any other national security threats, a group of people who are always considering viral threats. This wasn't all a surprise, and I think that's important for people to understand too. A lot of this was predictable, and so we have to make sure we have strategies, through policy to deal with that. And then the other piece of it as well is we can do things we didn't imagine being able to do before. And I'm not saying they're not without negative ramifications, but I don't think, a year ago we could even imagine this was possible to social distance like this and to do isolation like this. I don't think anybody would have said this was possible, but it is possible. I'm not there. There are some things we got to fix on the economic side of it, and that's probably what we should plan for the future. What's going to happen if, like, is there going to be a FEMA just for this, right? Is there going to be a very specific set of responses that go into effect if we have to do this? Maybe not using the unemployment system, but using the pandemic response system, right, to deal with those types of issues. But this is going to be a tool in the toolkit, I think, for the foreseeable future, and we're going to get better at planning for infectious pathologies.
Well, I'm sorry to have to end it, but I wanted to thank you and all your colleagues and all the first responders for putting your lives on the line. Jason has a family and a youngish son, and has to take his own family into account as he's putting his life on the line every day to protect all of us and save lives. So thank you so much, and hope to have you again some other time on Café con Tampa. Thanks so much, Jason. Talk to you later.
Thanks, Bill. Appreciate everybody. Take care.